Okay, all right. Thank you, Doc. I just noticed
You're
that.
welcome.
All right.
Yeah. So the fluid is moving from your intravascular to your extravascular space. So what that means is that the amount of fluid or blood you need in your blood vessels to get to your kidney would basically fall short, because now most of it is moving into your extravascular compartment. And fluid in your extravascular compartment won't go and supply your kidney. We need the fluid to be in the intravascular compartment. So once you have an edema, and you've got your fluid moving into the extravascular compartment, then there's going to be diminished blood flow to your kidneys. And once you have diminished blood flows to your kidneys, you are going to get the same effect, like the kind of effects you get when you have shock, right? So this reduced blood flow to the kidney is going to cause the kidney to fail, and that is hepatorenal syndrome. A similar thing can be said of hepatopulmonary syndrome. And this time around, your lung is failing because the liver has failed. And why do we say your lung has failed? Your lung is responsible for making sure you get enough oxygen into your blood. So when your lung fails, it means when we check your blood for oxygen, your saturation will be low. So you develop something we call hypoxemia or hypoxemia. And this hypoxemia is because, just like the first one, you got vasodilatation. This time around, so there's vasodilatation, there's edema, but then this edema and vasodilatation is happening in your lungs. And you remember we said there's pulmonary edema. As part of pulmonary edema, you'll be unable to breathe. And once you've got the edema happening in your lungs, then you are going to have decreased diffusion of oxygen across your alveolar into the bloodstream, right? So then it means you're going to have decreased amount of oxygen in the blood. So there's going to be what we call hypoxemia. And this hypoxemia is because the liver has failed. So that is hepatorenal and hepatopulmonary syndrome. Photopulmonary hypertension is just an increased hydrostatic pressure in the pulmonary blood vessels, and that in itself will lead to pulmonary edema, and hence there'll be difficulty in breathing. Are you okay?
Yes, sir, I'm okay.
All right.
I wanted to know if the lung fails, does it accumulate fluid in the lungs area?
Yeah, if we say your lung has failed, there are so many things that can cause your lung to fail. There are two main types of respiratory failure. There's type 1 and type 2 respiratory failure. And if you've got accumulation of fluid in the lungs, that means that the reason why the lung is failing, there's accumulation of fluid there. So we say, yes, that is type 1 respiratory failure. And you could have a type 2 whereby it's not the lung directly involved. There's something supposed to be happening for the lung to work, but it's not working. Maybe someone takes cocaine overdose, and because of the cocaine overdose, breathes so fast and gets tired and then is unable to breathe again. Then your lung will fail. So we call that type 2. That one, the lung is not directly involved. It's one of the things, but it's not always the case. But in the case of hepatopulmonary syndrome, accumulation of fluid happens because of what? The pulmonary vasodilatation. Daniel, are you okay?
Yes, sir, I'm fine, sir.
Okay, so I'll take 2 more questions and then we move on. If there are no questions, try as much as possible to read over the slides. Make sure you're paying attention to the complications. If a patient should come to you with chronic liver disease and ascites, you should be able to explain why there's ascites. You should make your specialist happy that, oh, the liver is not making enough albumin. So that's one of the reasons. 2, the pressure in the portal vessels has gone up. So that's another reason. 3, because there's poor supply to the kidneys, the renin adrenal angiotensin system has been activated, and this is causing more fluid retention. So more sodium, more water retention, and that's the reason why there's ascites. Then everybody is happy. Okay, so you should always be able to explain. If the patient comes to you vomiting blood, you should be able to tell us that, well, the pressure in the portal system is gone up, so collaterals are formed in the esophagus, what we call esophageal varices, and it's very common. And usually once you say that, the specialist is impressed because they don't expect you to know. So once you say that, then they are happy. Okay, so you make the specialist proud. Yes, please.
So, sir, in case in examination, maybe you ask for the complications.
Yes.
Yeah, you don't just list maybe renal failure and hepatopulmonary syndrome and leave it there. You just have to list and explain.
Oh no, you don't. No, you don't have to. You don't have to stress. If you see list the complication or states the complication, there's no need to explain the pathophysiology. But if there's a question on what is the pathophysiology behind this man's hematemesis, then you need to tell me that there's an esophageal virus which has developed, and probably has developed because of an increased portal pressure, and this virus has ruptured, and that's the reason why the patient is vomiting blood. Nice. You see, so if they ask you to
simple.
So if we ask you to explain the pathophysiology, I mean a simple like that.
Which I know it won't go that way.
but if we ask you to just state, and we ask you to state the complications, so then you should be careful if you see a question with someone vomiting blood and we ask you to state the other complication that may arise. I don't expect you to come and write the patient will vomit blood or come and write esophageal virus, because the question is already saying the patient is vomiting blood. So then I expect you to tell me the other things that may arise. Oh, this patient might develop hepatocellular carcinoma. This patient might develop a Photopulmonary Hypertension. This patient might develop hepatorenal syndrome. You see, those are the complications. But if there's a question where the patient has edema, patient has ascites, and patient is vomiting blood, those are supposed to give you clues that, oh, you are dealing with a patient with a chronic liver disease, complicated chronic liver disease, and all that. So if we ask you what other complications may arise, I don't expect to see ascites, because ascites is already in the question. Okay. Please read the slides. All right.
Sir,
yes, please.
We have a paper on Friday. Would the questions be difficult?
Drop the link.
So my you would have to decide as a class. If you check your timetable and it's favorable, you can always write my exams as your last paper. So you decide as a class when to write my exam. If Friday is too soon, let me know, and then we can all agree and arrange on that. So
are we writing with the regular students?
Yes, we are all writing together. So
and they are here, so we can discuss. Yeah.
After here, don't worry, I don't want to be part of your discussion. After here, you can decide as a class.
Yes, we'll do that.
Let me know. We still have to write before you guys go on vacation, because during vacation I would want us to have some other classes before you come back to school. Zoom classes. So whenever you have time, you let me know, you arrange, we'll have Zoom classes and finish some of the topics, so that when you come, it will be fast. And then I'll finish with you guys. So you decide after here and you let me know. Okay.
All right.
Okay. So let's try and finish up. So meningitis is quite an easy topic, and it's very important that you know, because you can be at the ER, they'll call you, doctor, a patient is having convulsion, seizure. You go and see, temperature will be skyrocketing high, patients having seizures, and you should be able to tell or make differentials of what is happening. Okay. If it's a child, usually you are thinking a febrile convulsion. A child 6 months to 6 years, febrile convulsion. Okay, so it brings you down a bit. fine, meningitis could also be there as a diagnosis. But if it goes beyond as an adult, you can't think febrile convulsion. So you can't hide behind a febrile convulsion. You have to be able to diagnose the reason why there's seizure and there's fever. And you should be able to manage it as such. Okay. So the need to know meningitis. And it's very essential you know about meningitis cause, especially when you are dealing with bacterial meningitis. Your patient can come in, and if you fail to diagnose, you lose your patient very, very fast. It has a rapid onset, it progresses so fast, and then you can lose your patient. So we need to be careful. So basically, meningitis, as the name suggests, because there's itis there, tells you that there's an inflammation of the meninges, and the meninges is what covers the brain matter, and usually you have the dura, arachnoid, and pia mater. So once you've got an inflammation of this, then we say you have meningitis. Okay, and this inflammation can be due to a direct extension from any of the structures close to the brain, or you could have a problem elsewhere. It gets into the blood and it spreads to the brain. Example, you could have pneumonia. We said one of the complications of pneumonia is meningitis. So you have pneumonia. Ideally, pneumonia is inflammation of the lungs, but then you end up developing sepsis, which means that your blood becomes infected. This blood gets to your brain, and then in addition to your pneumonia, you develop a meningitis. Okay, so could be a direct extension. So maybe you have some otitis media or infection in your ear, and then it spreads to the brain, or some infection in your nose, it spreads up and gets to the brain, or you decide to go and fight, someone sticks a knife into your head, you develop a cut, you don't manage it well, you decide to treat it at home, it gets infected, and then it spreads into your brain, and then you can develop a meningitis. Okay. So when you look at slide 4, I've given you the various causes, infective causes of meningitis. Mind you, once we're looking at meningitis, it's not only about infection. You could have other things causing meningitis. So meningitis can be infective or non-infective, but our focus today is going to be on infective, because that is what would push your patient faster. Usually the non-infective causes it runs a slow course, slow progression, and then we try to manage them. But infective, especially bacterial meningitis, is what will push your patient faster. So you have the Neisseria meningitidis. Class, just a minute, if you would hold on for me a bit.
All right.
Okay. Take that call. So can we go on, please?
Yes, Doc, let's continue.
Yes. So the infective, as I said, Usually with a bacterial, it runs a rapid course, right? So I've given you some common organisms that might cause it. You will definitely see it in your MCQs. HIV, of course, very, very important. So during the vacation, we'll treat some infectious diseases. We'll talk about HIV, so we'll talk about it in detail. Then there are other fungal infections too. The non-infective causes of meningitis would usually be the other causes of inflammation of the meninges that are not microorganisms. So you could have someone with some form of malignancy, and then you have the malignant cells invading the meninges. That's some form of meningitis, but that's a non-infective meningitis. Okay, so sometimes we give some medications through we call it intrathecal. So we give it through the dura and all that. So those things can irritate the meninges and then cause an inflammation. So that's more of a drug-induced meningitis. You could also have someone rupturing a blood vessel, causing a subarachnoid hemorrhage. And this subarachnoid hemorrhage, the blood irritates the meninges and can cause a meningitis. And then there are other things like sarcoidosis and amyloidosis. These are abnormal proteins that the body makes. So those are non-infective causes. You might also see that in your MCQ. Our main focus today will be on the ones that will come to you at the ER. So we'll be talking about infective meningitis, and specifically we'll be looking at bacterial meningitis. Okay. So what are the risk factors? So we are looking at people who tend to have some sort of immunosuppression. Okay. So, or people whose immune system are not so strong or so apt. So you could have people at the extreme ages. So the young people or elderly people, they are at risk. Conditions like diabetes, chronic kidney disease, you have a patient whose spleen has been taken out, cirrhosis, we just talked about that. All these conditions suppress your immune system and they put you at risk of meningitis. If you have someone with all these conditions being exposed to maybe Neisseria meningitidis, and then you have someone who doesn't have any of these conditions being exposed to Neisseria meningitidis, the person who definitely has these issues would stand a greater risk of having severe complications of meningitis. So risk factors are very important. People who abuse intravenous drugs, heroin and all that, they also tend to be at risk of developing meningitis. So when you look at the pathology, which is slide 7, you can see the acute bacterial, where usually you tend to have, once it's acute, then you know we are talking about polymorphs or polymorphic cells, so neutrophils. So the neutrophils will just infiltrate and then they tend to form a layer of pus, right? And the pus and all that will also affect your cranial nerves because they are coming from the brain. So you could have meningitis and then you have later complications of cranial nerve palsies. You have someone who's developed meningitis in the past and is unable to hear, okay, all because of the pus and all that, and then the formation of some sort of scarring there. So they tend to have issues with the nerve. Okay. Then you could also have a chronic infection like TB causing meningitis. And this time around, we are not going to have polymorphs, but we are going to have chronic inflammatory cells. Okay. And this chronic inflammatory cells would basically develop, it wouldn't be like pus-like as you see in your acute, but they are going to have gray, greenish exudates and all that. And then usually we know that in bacterial meningitis, what happens is that you develop some form of cerebral edema. So there's a raised intracranial pressure. Okay. Syphilis and all that too can cause chronic disease. With the viral one, you tend to have lots of lymphocytes. We know that if you have neutrophils or bacteria, viruses, the lymphocytes will you have predominantly lymphocytes there as your inflammatory cells. So once you tap your CSF, which we'll be seeing shortly, the type of cells you find in your CSF will point you to the direction of viral or bacterial, which is either acute or chronic. Okay, usually with viral, they don't tend to have cerebral edema. And so viral meningitis will tend to run a slower, not so severe course as compared to a bacterial meningitis. Of course, if an encephalitis develops in addition to the meningitis, then cerebral edema will develop. The difference between encephalitis and meningitis is encephalitis, there's an inflammation of the brain matter itself, whereas meningitis, there's just an inflammation of what's the meninges or the covering of the brain. Okay, so that's what encephalitis means. What are the clinical features? Once someone gets meningitis, there's the usual, please hold on. Once someone develops meningitis, there's the usual headache, neck stiffness, and then fever, what we call the meningitis syndrome. Okay, so they tend to have headache, they have a neck stiffness, they have a fever, and usually when the lights are so bright, they have issues, what we call photophobia. And then because of the raised intracranial pressure, they tend to vomit a lot. Okay, then with time, the raised intracranial pressure makes them drowsy. They can go into coma, they can have seizures, unconsciousness. Then they can have what we call lateralizing signs, meaning that they can develop some sort of paralysis and all that. Okay, because of the issues that the brain has, they can develop some sort of weakness in there. And then, as I said, they can have cranial nerve palsies because the cranial nerve is attached to the brain. So once you got any pus forming or anything inhibiting the function of the nerve, then you are going to have issues. The patient will be very, very irritable, okay? And then there's confusion and delirium as well. Some various organisms or some various causes of meningitis have peculiar things they come with. So for instance, if you see a patient who has meningitis and then there's what we call petechial rash or a reddish dots, what we call petechiae, it's most likely to be meningitis secondary to Neisseria meningitidis. Okay, if you have someone who has a skull fracture or an otitis media and develops meningitis afterwards, then it's most likely a pneumococcal infection. If you have a patient which has some sort of is immunocompromised and all that, then infection and cause meningitis. Okay, so all that. So maybe you can have a question and it will tell you which of the following are mapped. All the following are mapped properly, except then you have maybe petechiae to pneumococcal infection, and then you wouldn't have read the slide, so you go and choose, and that would be wrong. Okay, so you know that there are some clues which will point you to specific causes of meningitis. For example, if you have a rash and then you have pleuritic or stabbing chest pain with meningitis, then you know the likely causes and what enterovirals causing the meningitis. So usually, as we say that in bacterial infection, the progression is fast. So within hours, if you have a bacteria causing the meningitis, your neck stiffness will develop very, very fast. And there's something we call a Kernick's sign. Once you want to test for that, you ask your patient to lie down. Once you're doing your Kernick's sign, you are trying to test for meningeal irritation. So your patient lies down, then slowly you are going to lift the patient's leg, or let's say I'm going to flex the patient's hip. So you are lifting the patient thigh and then the leg up. you try and get something like a 90 degrees with your leg, the thigh, and the hip. And once you get a 90 degrees, you try to push the leg up. If there's meningeal irritation, your patient would scream. It will be very, very painful. Okay, that's a Koenig sign. There's also some other sign called Brzezinski sign, where you try to flex the patient's neck. And when you flex the patient's neck, the patient will lift up the legs in reaction to the neck flexion. It's called a Brzezinski sign. Once these signs are positive, then it tells you that meningeal irritation has happened. So most likely you are dealing with a meningitis. These signs will usually develop very fast, within hours, in bacterial meningitis, whereas in viral meningitis is very slow. Okay, very, very, very slow onset. So a patient comes to you with meningism and all that, then you are thinking, oh, if this is not meningitis, what could it be? As I said, it could be that the patient has bled into the brain, what we call a subarachnoid hemorrhage, which is irritating the meninges. Okay, it could also be that the meninges is actually fine, but then it's the brain matter itself which is inflamed, what we call encephalitis. Or it could be that the patient has a brain abscess. Sometimes we have patients coming to us with fever and seizures. We say, oh, this is classic meningitis. You go and do your CT scan and you find a collection of pus on the brain. That is a brain abscess. Okay, so you can have that there. And then you can have a cancer which basically has moved from somewhere, got into the meninges and irritated it. You could have a stroke. You could have a migraine, severe headache, and you might think this is meningitis, but it's just a migraine. Or you could have some tumor sitting in the brain, which is causing seizures and all that, but usually there will be no temperature in this case. Okay, so those are your differentials. Your investigations, because we are thinking an infection, you need to do a full blood count. It's very, very, very key. Then you need to do a kidney function test, because we know that if this infection can lead to sepsis, sepsis can lead to shock, shock can lead to kidney failure. So that's how we expect that you think through. So you are doing a kidney function test because you are looking out for septic shock, and septic shock can cause acute kidney failure. So you want to make sure the kidneys are working well. You need to check, do a lumbar puncture, get CSF, and then analyze your CSF. When you get a CSF, you are looking to see if you can find a bacteria. So you do a culture, you can do a microscopy. You test the CSF for sugar. Usually we expect that it's a bacterial infection. The sugar in the CSF is going to fall and all that, as compared to your serum blood sugar, okay? And then you can do a PCR on your CSF to detect the presence of the organism. If we are thinking syphilis is the possible cause of the meningitis, you test for syphilis as well. And then imaging comes in CT scan and then MRI scan. When you take your CSF, what are we looking out for? We are looking at the appearance of the CSF. We are looking at the type of cells present. We are looking at proteins, and we are looking at glucose. That would direct us to the type of meningitis we are dealing with. So if you look at the table here, normal CSF should be clear like water. Okay, you should have mononuclear cells less than 5. Your polymorphs, which are the neutrophils, you shouldn't have any neutrophils in there at all. The protein has a specific figure, about 0.2 to 0.4. And then the sugar in there is about 2/3 to half of your blood sugar, right? But when you have a classic bacterial meningitis, then this clear CSF becomes turbid. The mononuclear cells would increase slightly. Your polymorphs would increase. It will be very high, okay? Your proteins over there would also increase, and your blood sugar would fall less than half, because we know the bacteria would enjoy the sugar and drop the sugar in the CSF, okay? So that's it over there. If it's from tuberculosis, which usually cause a chronic meningitis sort of, then it also becomes turbid. You have mononuclear cells increasing, polymorphs would also increase, but the polymorphs will be higher acute bacteria than in chronic bacteria. And then your sugar would also fall because TB is caused by a bacteria. Usually your protein to be high. If it's viral, the appearance will still be clear. You are going to have mononuclear cells, which is the lymphocytes and all that. You are not going to have any polymorphs at all. Your protein would also increase slightly. And then instead of your glucose falling, your glucose is rather going to increase. Okay, so just know that usually in the bacterial meningitis, whether acute or chronic, your sugar will fall, whereas in viral, your sugar would be more than half of your blood glucose. So if your blood glucose at the time we are checking this CSF, your blood glucose is about 10, and then we check CSF glucose and we are getting 3, most likely we are dealing with a bacterial meningitis. However, if we check and we are getting about 6, it's more than half, and most likely we are dealing with what? A viral meningitis. Okay. So now, what do we do? The main thing we do is once we recognize this, we should start thinking treat, because the more you delay, the higher the risk of losing your patient. So your focus is on giving your fluids in case there's shock. You want to control seizures and make sure the patient doesn't have seizures, because when you have seizures, you lose control, your neck can fall back, your airway can become obstructed, and you can have problems breathing and your patient can die. So you make sure that your patient is not having a seizure. Or even if your patient is having a seizure, you are protecting the airway by putting an oropharyngeal airway there. Then you give oxygen, you start antibiotics promptly. Okay, there's something we call empiric. Empiric is antibiotic for the usual culprits. So when you start, you are waiting for your CSF for culture or your blood for culture so that you can choose your specific antibiotic needed. Okay, you can also control temperature with your IV paracetamol. Okay, if there's any pain, you try and manage with your analgesics. And then because you're dealing with inflammation, steroids therapy like dexamethasone may be very helpful when you are dealing with meningitis. And for bacterial meningitis, usually the empiric treatment is to give ceftriaxone 2 to 4 grams daily for about 7 to 10 days. If your patient has money, let the patient buy Rocephin. In case your culture comes and it tells you this is Neisseria meningitidis, there's a risk that they can infect other people when they go home. So you give them Cipro 500 milligrams that they will take it as a prophylaxis so that they don't infect the other people they'll be coming into contact with. If it's TB meningitis, you follow the protocol as such. Okay. So what I'll do is I'll drop the link now, put up a last link. I'll take questions and then we wrap up.